I am Dalia Basim. Our presentation is about biopsy in oral and maxillofacial surgery. Biopsy. It is the removal of a small piece of living tissue for microscopic examination or analysis and diagnosis. The use of biopsy is not only confined to the diagnosis of tumor but valuable in determining the nature of any unusual lesion. Indication of biopsy: any lesion that persists for more than 2 weeks with no apparent etiologic basis, and any lesion that does not respond to local treatment after removal of local irritant. Persistent hyperkeratotic change in the surface tissue, as we see in the pictures, and bone lesion that not specifically identified by clinical or radiographical findings, and inflammatory change of unknown cause that persist for long periods. Any lesion that has a clinical characteristic of malignancy to determine the nature of abnormal lesion with unknown cause. Contraindications of biopsy: we have a relative contraindications and absolute contraindications. Relative contraindications: in normal and anatomic racial variation, such as a physiologic pigmentation as we see in the picture on the right side, and leukodema and linea alba. Linea alba is the picture on the left side, and exostosis and tori in the picture below in the slide. And in the compromised patient health of the patient with a history of bleeding disorder, including patient on anticoagulant therapy, and the proximity of the lesion to vital anatomic structure, and lesion in the area of difficult surgical access. The absolute contraindication: in the pulsative lesion or lesion that is suggestive of vascular nature, and intrabony radiolucent lesion should be aspirated prior to incision, and in the pigmented lesion should not be biopsied incisionally. Types of biopsies: the first type is incisional biopsy. Incisional biopsy is the biopsy that samples only a particular or representative part of the lesion. If the lesion is large or has a different characteristic at different locations, more than one area of the lesion may need to be sampled. Indication of incisional biopsy: if the area under investigation appears difficult to be excised, the lesion in which the diagnosis will determine whether the treatment should be conservative or radical, and if whatever there is a suspicious of malignancy. The principle of incisional biopsy: the biopsy site should be selected in area that show complete tissue change. Necrotic tissue should be avoided. The material should be taken from the edge of the lesion to include adequate to normal tissue change, and we should take a deep, narrow biopsy rather than a broad, shallow one, as we see in the picture. The second type is the excisional biopsy. Excisional biopsy, it means the removal of an entire lesion at the time of surgical diagnostic procedure, as we see in the picture. The perimeters of normal tissues surrounding the lesion is excised to ensure the total removal. Indication of excisional biopsy: it indicates for smaller lesion, and the procedure the entire lesion with 2 to 3 millimeter of normal surrounding tissue is excised, and we should do the excisional biopsy on the lesion that appear to be benign on the clinical examination. Bunch biopsy involves a special instrument called bunch for removal of portion of a lesion. The bunch is composed of a circular blade attached to a pencil-like handle. The instrument is gently rotated with the firm downward pressure. The bunch is pushed down until the subcutaneous fat is reached. Bunch biopsy can remove the entire depth of the lesion, but they are difficult to use on certain locations, such as where bone is close to skin. In this method, the surgical instrument fills out the small segment of tissue from inaccessible lesion or from large lesion where excision is contraindicated. Here is the steps of bunch biopsy. We have in the picture a suspicious lesion on the tongue, and we do the bunch biopsy with the bunch instrument and ready for incision, and the incision made in the picture, and here the specimen removed by a scissor, and coagulation obtained by gauze pressure, and then the specimen is removed and ready for fixation, and then we do the microscopic examination. Another type of biopsy is fine needle aspiration biopsy. Fine needle aspiration is the use of needle and syringe to penetrate a lesion for aspiration of its content. Indication: in all fluctuant lesions that contain a fluid, or any intraosseous radiolucent lesion before surgical expiration, also to rule out a vascular lesion. The procedure of fine needle aspiration biopsy: a sample of tissue is obtained by passing a needle into a suspected mass. Suction is then produced by a syringe, and needle is moved back and forth rapidly in the tissue, and small shavings of tissue are obtained in the barrel of the syringe that are later fixed on a slide and examined under the microscope, as we see in the picture. And this is aspiration technique. We do it on swelling on the neck, and we aspirate the fluid by passing a needle, and here we're preparing a slide, and we should do the microscopic examination. Oral exfoliative cytology is the microscopic examination of shed cell from the epithelial surface, and it is a rapid, non-invasive procedure valuable in screening patients with oral lesion. The equipment of this oral exfoliative cytology is the glass slide, cytobrush or wooden steel spatula, cotton, gauze, and mouth mirror, and probe. Indications: periodic review of oral pre-malignant lesion and oral cancer patient, and when biopsy is contraindicated on medical grounds, and in diagnosis of lesion like herpes simplex, pemphigus vulgaris, and white sponge nevus, as we see in the pictures, and in the patient who refused the biopsy. Thank you.
Hi everyone, my name is Dalia Saad, and I'm going to continue the presentation about biopsy. Here we have brush biopsy. It requires a special a sterile brush that's designed to penetrate to the basement membrane and thus achieve a complete transepithelial specimen and obtain cells from all three epithelial layers, superficial, intermediate, and basal layers. Unlike the cytology, collect only the superficial cells. As we can see here in this photo is the brush biopsy. Indications: epithelial abnormalities such as leukoplakia, erythroplakia, chronic ulcers, mucosa that is atrophic, thickened, and traumatized. Here we have the leukoplakia and chronic ulcers, also the mucosa, which is traumatized. While the contraindications include lesions with intact normal epithelium, fibromas, mucocele, hemangiomas, submucosal masses, pigmented lesions, and amalgam tattoos, also highly suspicious lesions. Here we have in this photo on the left side is the amalgam tattoos near the amalgam filling, and on the right side is the mucocele, which is contraindicated for the brush biopsy. In this photo on the left side we have hemangioma, and on the right side we have fibroma, also contraindicated for brush biopsy. Here we have the highly suspicious lesions, also contraindicated. Now we have shave biopsy, which is best for raised lesions, mostly confined to epidermis. Include benign nevi, small nodular basal cell carcinomas, and squamous cell carcinoma, actinic keratosis. It is not indicated for suspected melanoma. The steps of the shave biopsy, as in the photos, we use a sharp blade to remove and take the lesion. After that, we place an aluminum chloride with the cotton swab to achieve hemostasis. Now we have electrosurgery biopsy. Electrosurgery biopsy refers to cutting and coagulation of tissue using very high frequency and low voltage electrical currents. It is useful in producing a bloodless operative field. Lesion excisions on the face are usually performed with only cutting current to limit scarring at the wound base, which can be produced by the effect of thermal coagulation. Technique as shown in the photo, the lesion is grasped by the forceps through the loop electrode. The electrode is activated going under the lesion, removing the growth. Exploratory biopsy, it is done for the investigation of an internal lesion. In this, removal of all portion of tissue exposed is done. This is commonly employed for the intraosseous lesions of maxilla and mandible. Curettage biopsy is used primarily for intraosseous lesions and very friable cellular lesions where only small amounts of surface material are necessary for evaluation. Extremely small tissues are centrifuged and sedimentary segments are placed in agar media and then sectioned as tissue blocks, used successfully on lesions like actinic keratosis and warts. Imprint cytology. Imprint cytology, in this technique, the biopsy tissue is cut into two halves and the cut surface is touched to the slide. The slide is stained later to see the exfoliated cells. This provides a rapid preliminary diagnosis, can be reported within an hour. Equipments for the imprint cytology, we need mouth mirror, probe, antiseptic agent, local anesthetic agent, syringe, and blade number 15. surgical scissors and tissue forceps, bone curette, small hemostat, and 10% neutral buffered formalin, and sterile saline irrigation. Principles of biopsy. We must know the principles. Mucoperiosteal flaps should be designed to allow adequate access for incisional and excisional biopsy. Incisions should be over sound bone. Cortical perforation must be considered when designed flaps. Flaps should be full thickness. Major and neurovascular structures should be avoided. Incision. Sharp scalpel should be used to incise tissues for routine conventional biopsy. 2 incisions forming an ellipse at the surface and converging a V-shaped letter at the base of the lesion provide a good specimen and leave a wound that easy to close. So the wound the specimen must be thin, deep, and are preferable to the broad, shallow specimens. Periphery of the normal appearing tissue should be included in both incisional and excisional biopsy specimen. Excisional biopsy, we make an incision around the lesion, and we make it deep V letter. After that, we incise we take the biopsy, and with a blunt undermining of mucosa of wound margins after the removal of the lesion, and then we do suturing. Identification of surgical margin. The margins of the biopsy specimen should be marked with a silk suture to orient the specimen to the pathologist. Specimen care. After removal of the tissue should be placed immediately in 10% formalin solution, at least 20 times the volume of surgical specimen. Specimen should be placed in a wide open bottle. Leakage of formalin should be prevented. Complications of oral biopsy. We have many complications such as hemorrhage, and infection, and poor wound healing, reaction to local anesthetic. Here we have palatal ulcer. Also spread of tumor cells after the biopsy, injury to adjacent tissue. Guidelines for an appropriate biopsy. An incisional biopsy, we take the incisional biopsy for chronic ulcer or squamous cell carcinoma. Also, we have leukoplakia and erythroplakia. We take an incisional or punch biopsy of the worst area. Also, bullous lesion in pemphigus and pemphigoid, etc. Incisional or punch biopsy of unaffected mucosa close to bullar erosion plus fresh tissue specimen. Mucocele, we do a careful excision biopsy, like in this photo on below. With pyogenic granuloma and Apolis, we use excision biopsy. The minor salivary gland tumor on pellet, we do a deep incisional biopsy. Also, a major salivary gland tumor, we use fine needle aspiration cone biopsy, as in this photo below. We use the fine needle aspiration for the parotid gland. And thank you.